All right, we're live. Hello, everybody. This is Kyla here from Nutritional Revolution, and today we have an amazing guest for you guys. We have Dr. Lara Briden here. She's going to help us dive into all things loss of menstrual cycle, amenorrhea, all that fun stuff we can dive into, learn some more, gain some knowledge here. But first, I'm just going to let Dr. Lara Briden introduce herself, let us know a little bit about her background and how she got into the field and what we're going to talk about today.
Yeah, for sure. Thanks, Kyla. Thanks for having me. So I'm a naturopathic doctor. I currently live and practice in Christchurch, New Zealand, but I'm Canadian. You can hear from my accent. I trained at the Canadian College of Naturopathic Medicine in Toronto, and I graduated 25 years ago. So that's a long time. I've been pretty much on the ground since then, full-time, Monday to Friday, 9 to 5, treating people, mostly women, for period problems. About 5 or 6 years ago, I wrote my first book called Period Repair Manual, which we'll probably talk a lot about today. That's kind of harnessing my 20 years of knowledge of what works for periods. I have a second book called Hormone Repair Manual for women over 40, which we may or may not get to today, but that's a different, slightly different conversation. And then the other thing to mention that might be interesting to you is that before I became a naturopathic doctor, I was an evolutionary biologist.
Cool.
And I published a peer-reviewed paper about sex differences in feeding and foraging behavior in bats. So we put little radio tags on bats, and just to give you an example of, like, I don't know why I'm sharing this, but I just feel like you might be interested. So in the bat world, males use something called torpor. It's a daily hibernation. So they head out, they eat for 20 minutes, and then they pretty much sleep the rest of the night. Like, they're done. Like, they don't need very much food at all. The females, because they're gestating and lactating and they have to feed 3 long sessions through the night. They never go into torpor. And so they're just they're hot and active all night compared to the males. So that was sort of a, early indication of my interest in female physiology and how important it is. And I guess, just framing that, I actually tend to view sex differences in physiology as the female is the standard normal version, and then males are like they're like a special side issue. They've got different things going on. They don't have the same requirements as females.
That's so interesting. I love learning about that stuff.
Yeah.
So cool. So thank you for sharing that. So where I really thought having you as a guest would be so beneficial for our audience is we do work with mainly endurance athletes, but I will say mostly women endurance athletes as well. And we get a lot of female athletes coming to us, where, especially in like the triathlon world, where they're clocking, 14 up to 20 hours a week. And to fuel something like that is quite a feat. Like, eating becomes your second job. And so we see a lot of women lose their menstrual cycle. Maybe it's just part of the year. Maybe it's in their bigger training phases, or maybe they didn't have a cycle like ever and are trying to kind of get that back. So I think kind of touching in on like amenorrhea, loss of menstrual cycle, all of that stuff, I think would be a great topic of discussion for our audience and our clients as well. So where should we start?
Well, why don't we start with why it's important to have a menstrual cycle? Let's start there.
Yeah.
And then we can sort of flow on from that. So regular ovulation is how we make hormones. It's how we make estrogen and progesterone. And this is one of my big talking points in my work. And we need those hormones. So we need them for general health. I would argue we need them for performance as well in sports. And I can speak to this a little bit. I know there's been, in part, sort of a narrative that female hormones are a liability of some sort, but that is actually not what the research shows. Contraceptive drugs and the pill can be potentially a liability, but our own hormones, especially estrogen has as you probably know, it's anabolic. It sensitizes to insulin. Like, the mitochondria seriously love estradiol. They have this really intimate relationship going on with estradiol. So it's important for short-term performance and also just long-term health, as you know. So it helps to build bone, create some metabolic reserve in the cardiovascular system, and just generally, set us up to be healthier. Progesterone has benefits as well. That's the hormone in the second half of the cycle that you only get from ovulation. That may be a little more nuanced. I think there's arguably some aspects of progesterone are not great for sometimes for some aspects of short-term performance, but it's still overall, there's some surprising bits of research that it's, also has benefits. It certainly helps to reduce inflammation in the body, supports immune function, it's calming for the brain, helps to regulate the stress response systems, helps with sleep. So there's definitely things going on. And to sort of the framing, not just for athletes, but for women in general, has unfortunately kind of been that, you only need ovulation when you're ready to make a baby, which is crazy, because the thing I often say is that would be like saying to men, you only need testosterone when you're ready to make a baby, which is obviously ludicrous. Right. So, we do need ovulation. Actually, I'll just, on the topic of testosterone, we also make testosterone, as you know, and we make this really fascinating little bump up in testosterone just before ovulation that has been observed, especially in the athlete population, as giving almost superhuman powers. It's like these few days of, if you sort of layer on the estradiol surge that's happening pre-ovulatory, and then you get this little bump up of testosterone to which females are very sensitive, you can get this little, sort of outgoing. That'd be more, I guess, maybe for like team sports or, faster sports, but it's just quite fascinating.
I can speak to that. I have noticed that when you start kind of tracking your cycle or doing basal body temp tracking and those kind of things, and you're an athlete and you're performing, you definitely notice that, like, I'm right there in my cycle right now. So I'm like, exercise feels really good. You're really excited. You feel strong. Like, yes, I can speak to that anecdotally for sure. That's awesome.
It's really nice. And actually, just on the topic of testosterone, there is also, on the other side of it, I'm not sure if anyone in your audience would be dealing with PCOS. We can circle back to that, but that's the state of kind of chronically elevated androgens, which is actually not good for the female body. That is some issues around that. But before I know I'm jumping around a little bit, but I just want to sort of finish the idea that we need ovulatory menstrual cycles. There also is a narrative out there, which I always like to, debunk, which is that, our ancestors didn't menstruate as much as we do, kind of. And some of the time it's because they were under fueling, not intentionally, potentially, not intentionally, but just because food was scarce. But what the research seems to show is, they were still menstruating. I mean, certainly modern day hunter-gatherer groups do menstruate, but the difference is they were obviously pregnant or breastfeeding a lot more of the time.
Right.
And so I'd like to respond to that in the sense that, losing your period to underfueling is not the same as being pregnant or breastfeeding, because just speaking to how beneficial female hormones are for us. Obviously, pregnancy is a high hormone state that I would argue that gives a lot of benefits in terms of building metabolic reserve. Whereas underfueling amenorrhea is a very low hormone state. So the argument that, we never used to have periods, therefore we don't need them now, doesn't hold up at all.
Yeah.
And into all of this also comes the conversation about hormonal birth control, which I'm not sure how much time you want to spend on that, but that, just broadly speaking, hormonal birth control, almost all types, except for the hormonal IUD, shuts down ovulation. So it is robbing women of the benefits of the hormones that I just spoke about, and it's replacing those hormones with contraceptive drugs, which are not molecularly the same as estradiol and progesterone. So we're not potentially not getting the benefits from those at all.
Yeah. So with something like a copper IUD, no hormones present.
Oh, right. A copper IUD does not alter or change hormones. Absolutely. So that's one option. I mean, there's condoms, there's obviously fertility awareness-based methods. There's lots of ways. And I've written about that extensively in Period to Pair Manual, just different options for avoiding pregnancy. But
yeah. So you had mentioned prior to us hitting record, the stages of amenorrhea. I would love for you to dive into that.
Yes. So let's talk about that. So some of this I'm getting from my conversations with Professor Geraldine Pryor, who is the reproductive endocrinologist who helped me with both books. She's amazing.
If you ever get a chance,
she's super busy, but
yes,
she's been a champion of progesterone for decades. I've also spoken to some researchers studying menstrual cycle in athletes there, as thank goodness there's a lot more of that happening now, which is
amazing.
Great.
Yes.
And what some of the researchers are realizing now, at least the ones I've talked to, is that it's not enough to just track bleeds and say, are bleeds happening semi-regularly? It's also important to understand if ovulation is happening. And this is how I'm entering into your question about the stages of losing your period. So a healthy menstrual cycle has approximately monthly ovulation. It doesn't have to be a 30-day cycle. It could stretch out. It could easily, especially in younger women, it could be 40 days, 45 days. That's okay, as long as it's ovulatory. So with an ovulation, healthy ovulation, there will then be 2 of progesterone production, and progesterone has a period lightening effect. So one of the early phases, potentially for some women, athletes under fueling, is there can be a shortening of the luteal phase, so less progesterone. So one of the early signs can be heavy periods, which is a little
interesting.
bit, and that doesn't happen to everyone, but that can be a sign if people are like, oh, since I've been overtraining, my periods got heavier. That is potentially what's going on. And of course, heavier periods can lead to iron loss and not good. So then that's kind of early phase. The second phase, or sort of on that gradient, would be not ovulating at all, but still having bleeds. So those would be anovulatory cycles. That's actually not uncommon, even amongst women who are eating enough. These are called, they're called anovulatory cycles. I think it's a really helpful concept to know about. Typically, anovulatory cycles, well, they can even be somewhat regular. They can be irregular. And the bleed itself can be different lengths. But one pattern with anovulatory cycles is they can be longer bleeds. So you might get this like where you bleed for 10 days. You could even have like a light bleed for 10 days. And that's often a sign that that's what's going on. So that's kind of the middle phase. And then eventually, obviously, when the underfueling is more severe, then there's no bleed at all. Like there's amenorrhea.
And so jumping back to kind of that phase 2, that anovulatory cycle, is there a way for someone to test for that before getting to that, like, okay, my cycle's gone for 10 days, very light or very heavy, this is unusual? Is there a way for someone to test?
Perfect question. So okay, so we'll talk about, I'm going to talk about 2 things here. So we'll talk about how to sort of know if you're ovulating just yourself, and how some of the researchers are trying to track this. And then we'll talk about, an assessment or a medical workup or blood test to try to work out why someone's having anovulatory cycles or why their periods have stopped. Obviously, in this, in your audience, the most likely explanation is underfueling, but there can be other reasons, right? So you still need to potentially have that workup. So the first thing, tracking ovulation, some of the researchers are using, ovulation test strips where you like pee and you measure for something called the LH surge. That's one way. Pee on a stick, or, you do a urine test for LH. But the best way by far is tracking temperatures, body temperatures. And so there's some wearable devices to do that. You can just do that with an old fashioned thermometer under the tongue. It's a basal body temperature. So you want like that temperature when you're lying in bed, not after you've been moving around and generating heat with your muscles. And as you may know, ovulation is associated with a 0.3 degrees Celsius because I'm Canadian, or a 0.5 degree Fahrenheit sustained temperature rise in the luteal phase, because progesterone increases metabolic rate by that much, by about 300 calories a day, actually, which is quite interesting. So you're looking for that, not just the existence of the temperature shift, but the duration of it. Like you want to see a nice, robust, what Professor Pryor calls robust luteal phase. And so that's something people can just track. I mean, I think what's an interesting story is some of the first biohacking kind of wearable tracking devices, I guess Apple put them out or whatever that was, a decade ago, did not include tracking your menstrual cycle with basal body temperatures. I was just like, at the time, I'm like, they missed the most obvious, like almost the number one thing you can track with the human body is this like ovulatory temperature shift.
Right.
So that's an easy way to sort of observe if you're ovulating at least some of the time. And just for everyone listening, it's okay if you have a cycle where you didn't ovulate. Like that's, we all do, even non-athletes do, but the message is you want to be having at least some portion of them as ovulatory cycles. That's a really good sign that you're eating enough. And also it's beneficial for health because progesterone every month is beneficial for health.
Yeah. Amazing. So once we've gotten into the amenorrhea, the full amenorrhea, there's is it 3 months of no cycles that is considered like, and is that is hypothalamic amenorrhea? Okay.
Or REDS. So in your space, it's called relative energy deficiency in sport. In a non-sports context, it's called hypothalamic amenorrhea. It's the same thing. It's under fueling for the amount of activity. And as you know, you probably know this, but I'll just explain. It's not the body malfunctioning in any way. Like it's the brain going, there is not enough food to make a baby. And even if you don't want to make a baby, this doesn't matter because this is how this is how ovulation, works. Your body has to be convinced there's enough food coming in. It's not just about body weight either. It's about the energy coming in, like the hypothalamus perceiving that. And I would argue there's going to be a macronutrient aspect to that. I think in my book, I talk about something called Ovarian Setpoint, quoting another researcher, and just how depending on your ancestry essentially and what your ancestors were relying on, if certain women, not all, but I think do need a certain degree of carbohydrate signal in their food supply to convince their hypothalamus that it's going to be okay. Because think about it, to make a baby requires in total 70,000 additional calories over the next 9 months, over baseline kind of thing. So it's a lot, right? So the brain's like, am I going to be able to do this or not? And something that's quite interesting from an evolutionary perspective is that humans were one of the few mammals that can't they're sort of all in with pregnancies. Like a lot of mammals will, if there's not enough food coming in, they just quietly reabsorb the pregnancy and just carry on. Like, they don't have to lose it or, miscarry it or anything like that. But whereas with humans, like once you're pregnant, you're kind of all in, like your body doesn't have an easy way out of that.
Right.
So this is why I think, especially in younger women, the brain is being really quite careful to make sure that's, it's a safe time to do that. So that's obviously the mechanism for losing periods. And
so with several of our clients, like we will get athletes, triathletes putting in tons of hours a week where the energy needed to come in to support that training output, when we give them their numbers and their calculations, a lot of times it's like, whoa, wait a minute, right? This is a lot of food. And so we get this realization of like, wow, they really were not consuming enough calories. And that's likely what's contributing to maybe the loss of cycle or the irregular cycles or things like that. And so in a situation like that, I will also say too, we have some female athletes who are using birth control. I know potentially coming off birth control and then kind of that waiting game of like, when does the period come back? And maybe could you touch a little bit on like post pill, potentially amenorrhea and that kind of arena as well?
Yeah. We can also combine that with what I was going to talk about is the testing for amenorrhea and what's involved. So, gosh, there's a big rainbow outside my window right now.
Amazing.
One thing I was going to say too about the needing to fuel enough, because, and I think you can, confirm whether I've got this right, but I've only learned this in the past maybe 4 or 5 years, that intense exercise, at least in women, can have an appetite suppressing effect, which is double whammy. Like, so my understanding with athletes, and I'm not an athlete personally, but is that you can't trust your appetite anymore. Like you have to, like you say, eating becomes a full-time job. Like you have to calculate it. You have to lay it all out and force yourself to eat, which is not, you can imagine, not that easy. So
it's definitely more common in our runners for sure. That kind of that combination maybe of the jostling of the stomach, that seems to be more severe, that post-training suppression of appetite compared to maybe our cyclists or our swimmers. But it is a real problem because they want to listen to their body, right? And the body's saying, I'm not hungry. My stomach's all turned upside down or, from that run. And so they'll go several hours without eating, but then the appetite comes back with like a vengeance, maybe like 4-6 hours later or that evening or the next day. That's definitely a kind of a problem where we try and educate clients in that area of like, can we find something that maybe is like a little bit more liquid, maybe more tolerable to be consumed post-training, and kind of like start slowly turning back on that digestive system and getting the system learning how to, or wanting eventually to eat something after exercise like that.
I'll just comment about that. I am going to get to your question about post-pill and assessment and everything, but just to say too, because of course I'm a naturopathic doctor, so I have a big focus on digestive health.
Oh, yes.
Stereotypical for naturopaths, so we're like always thinking about digestion. So that's something certainly I've encountered, that if there are digestive problems like a dysbiosis or something called small intestinal bacterial overgrowth or SIBO, that can make it even harder to eat enough because you're bloating and not feeling great. So I would make the argument that in that case, it then actually becomes priority to try to address those digestive issues. That can sometimes mean just ever so, broadly. I'll just give an example. Like I think sensitivity to cow's dairy affects about 1 in 3 people. So it's not everyone, but there's a few people out there who do not do well on milk, and if they're trying to use milk to fuel, they're potentially like just having an inflamed digestion and not absorbing nutrients and not being able to eat. Like it becomes, even though ideally milk is quite high calorie and providing a lot of things on paper, for some people that's not a good solution. So that's just an example of also addressing digestion. And as part of the pathway to being able to eat enough and get your period back, which is a lot of what we're talking about today.
Yes, definitely. That milk area is something where in a lot of the GI in endurance athlete research, there's been a lot of discussion around like decreasing fiber leading up to like big events and things like that. And one of the things that they continue to hit on is minimizing dairy consumption leading up, even if you're not necessarily lactose intolerant or things like that, as being one of those things that could potentially contribute to continued. But I'm sure there's an underlying factor of why it would contribute to some of the people that they studied, right? Where it was obviously enough of a correlation to show that it is a problem and something to avoid. It is an interesting area.
And it's not just lactose in dairy. I talk about this in both my books, actually. I think a lot of the inflammatory effect of dairy is casein. When casein, the normal casein in cow's dairy. So that's something people can look into as well.
Interesting. Because the lactose, I'm sure you could touch on this, right? Is lactose is present in some dairy products more so than others, right? Like cheeses.
I'll just say again, so in my book, so I go really big into like A1 versus A2 dairy. So A2 dairy would be goat and sheep and Jersey cow, and A2 bred cows. And it doesn't have the inflammatory casein. And I find actually people who thought they were lactose intolerant, when they get off the inflammatory casein, they actually find they can tolerate the lactose in some of those products. So that's just another kind of broadening out. Often the symptom of a casein sensitivity is that congestion from dairy, not just the maybe diarrhea, but like actually sort of mucousy and inflamed.
Interesting. So definitely not something good to consume prior to endurance activity. We need to breathe really well, right? Oh my goodness. All right. So let's see, we were going to dive into conversations around post-pill, amenorrhea, and testing.
Okay. Let's do that. So let's start with hormonal birth control, and let's start with the fact that pill bleeds are not periods. So this should be very basic knowledge, but for some reason,
news to a lot of people.
Even a lot of doctors don't understand this, unfortunately. So on a combined pill, one that has this estrogenic drug in it, there will be, potentially there'll be like a uterine buildup and then a withdrawal from the drugs. And that can be dosed, that can be given monthly.
Mm-hmm.
Like there's actually no medical reason to bleed monthly on those drugs. So potentially there's really, if you're going to take the combined pill, there's really no reason to have a monthly bleed anyway.
Mm-hmm.
And require tampons and all that goes involved with the bleed. I mean, obviously I'm not a fan of the pill, but different reasons. But just to be clear, a pill bleed's not a period. Now it can happen that actually in severe underfueling, there won't even be a pill bleed. And that's actually just to do with very low insulin and just not being able to even build up a uterine lining, even in the face of the estrogen contraceptive drug. But for a lot of women, they will be getting a pill bleed. And I mentioned this just because then you get the phrasing like, oh, I stopped the pill and I lost my period. It's like, no, like you actually hadn't had a period. Right. Your last period was before you took the pill. If you were having periods, like those are not periods. So you can't, compare them. Just on the topic, just to, make sure I've covered everything. So it's only the combined estrogen methods, would be the pill or NuvaRing or the patch, that gives an induced bleed. Progestin only methods, including the mini pill, the implant, the injection, the depot injection, which I hope none of your athletes are on, but that's a whole different story. That's really bad for you. But the, implant or mini pill, because they permit some estrogen, but inadvertently suppress ovulation, they will cause anovulatory cycles. We talked about that before. So they'll cause an anovulatory bleeding. So there could be somewhat regular or irregular bleeding or no bleeding on those methods.
Interesting.
The hormonal IUD does not, as a rule, suppress ovulation. So it's interesting because it's actually one of the few, it's one of the few situations when you can weirdly, on the hormonal IUD, you can ovulate, get ovulatory cycles, still be making all the estradiol and progesterone I talked about at the beginning.
Yeah.
But not bleeding, which is very weird because actually it works locally in the uterus to thin the uterine lining. It can still, the hormonal IUD is not without its side effects potentially. I have a blog post called The Pros and Cons of the Hormonal IUD, and people could check that out.
Perfect.
But it, I guess if I had to say, like, of all the methods of hormonal IUD, which is the best, I'd say from a physiological perspective, I'd say the reason hormonal IUD is probably the best because it permits ovulatory cycles some of the time. Often not in the first year when the dose of the drug is higher, especially in younger women, they may still switch to anovulatory cycles and potentially no bleeds. So that's the hormonal IUD. So then we're in the situation of amenorrhea post-pill. So potentially in the situation where you were having pill bleeds and then came off the pill, obviously you're not having induced bleeds anymore. So then your underlying situation has been revealed, unmasked. This is now the real, and this is actually one of the dangers of the pill actually for athletes, is if it is causing, if you're getting the regular drug bleeds, induced bleeds from that, you won't be aware maybe that you're underfueling because the switch to anovulatory, the longer cycles, the eventually losing your period is all a good barometer or indicator of health generally and of fueling in particular. So being on the pill masks that, which is not good because as you know, there's other dangers from underfueling, not just losing your period, but for your bones and actually what the research now is the pill does not protect bones the way everyone wished it would or hoped it would. There's other strategies. We'll see how much we get to today, but bone health is really important. And I guess I would just mention that rather than the pill to try to protect bones, the evidence-based approach for that is while a woman is trying to fuel enough to recover her own cycles and make her own hormones, the evidence-based treatment is actually using hormone therapy, like menopausal hormone therapy, which is mostly these days body identical, which means actually taking actual estradiol and progesterone identical to what our body would normally make. So that's very different than what's in the pill. Right. Hopefully that's clear. I've written about that extensively. So if people are kind of pondering that, they can have a look at some of those resources.
Have you, there was a recent, I think it was the female athlete conference, this last year where there was a discussion regarding kind of what you mentioned, like the OCPs, the oral contraceptives,
Yes.
the estrogen present in there was not there. The research was not kind of leaning towards supporting of the bone health.
Yeah,
Whereas
I know.
I believe they said the estrogen patch was like, if
Yes.
anything, that was going to be the way to go for
Okay.
bone health.
Yeah.
Right.
So this is exactly, okay, perfect. That's exactly what I'm talking about. So that everyone's on the same page. So the estrogen patch that is used for menopausal hormone therapy is what's called body identical estradiol. So it's the exact same estradiol that we make. Like, here's a way to kind of illustrate that point. Like, there's you can do a blood test for estradiol and progesterone, the two hormones that we make, that shows up on a blood test. If you, on the pill, if you do that blood test, you have none of those hormones. Like, you have menopausal levels, because in addition to maybe not having your period, the pill suppresses ovarian function more. But whereas on the patch, you'll see the hormone show up on blood test. And then the companion to the patch is something called Prometrium in the US. It has a different brand. It's Utrogestin in some countries. That is body identical progesterone that, there's different prescribing ways, but often it'll be the patch every daily, and then the progesterone 2 weeks on, 2 weeks off. And that can give, the right support for bones until ovulatory cycles are regained. It's not instead of having ovulatory cycles. Like, I would just say, the idea is you're still increasing your fueling, so you get your periods back, and then you don't need those hormones anymore.
Yes.
Because you're not in menopause, so you shouldn't be on menopausal hormone therapy long term, right? Like,
yes. Definitely. Yeah. It is very interesting. When hearing that research regarding that, because that has been something that was claimed for quite a while, I think.
I know. I was just wishful thinking, really, and sort of not understanding how female bodies work, and and there's sort of this long-term assumption that the contraceptive drugs are close enough to hormones that they'll be good enough, and they're not. They're just not.
And that's something too we see. I mean, thinking about kind of the conversation around underfueling, loss of menstrual cycle, decreased bone density tends to be one of the side effects. Then you combine that with an OCP where it's likely not supporting bone health.
Exactly.
And maybe someone who is having maybe a quote unquote pill bleed and is taking OCP thinks they're supporting their bone health, but yet we have these endurance athletes getting fractures and, breaking bones or injured, getting regularly injured. And so I think that's something that needs to be kind of maybe talked about more, but definitely I think our audience would benefit from just kind of like, knowing that as well, and hearing that this conversation around the estrogen present in these OCPs is not necessarily what's going to support your bone health. And I do think that there's still plenty of OBGYNs that are saying that they do, right? And
I know. I think one of the reasons the pill doesn't perform well in terms of bone health is that it is the progesterone side of things too. Like, there's Professor Pryor, who I mentioned earlier. She's so amazing. She has done she's a scientist as well as a clinician. She's done a couple of studies on the role of progesterone, real progesterone, not the progestin contraceptive drugs, but real progesterone in terms of supporting bone health. So I think this is where ovulatory cycles and making our own hormones can outshine the pill in every way. And a big part of it is because we get that progesterone benefit for bones. So
that makes sense. So when someone comes from maybe post pill, or maybe they did lose their cycle and they're realizing, okay, this is not a good place for me to be. Maybe I'm getting injured. I'm getting fractures. I know I'm under fueling because Kyla did a nutrient analysis for me or whatever it is. What is kind of a potential timeline? I mean, once we get calories back in a good place, like what can someone potentially expect, or hope for?
Exactly. So I'll answer that first, and then I'll just do a brief discussion of like, the differential diagnosis, or just some of the assessment that doctors might do when women lose their periods. But it takes minimum 4 months, usually 6 months, up to 12 months to get your period back once you start fueling enough. And there's just a lag time with that communication between the brain and the ovaries. And it takes, for example, ovarian follicles take 100 days to develop. So there's a built-in lag time with the system. And so you can't expect to, to regain your period after 1 or 2 months of increased fueling. It might happen if you were sort of on your way there anyway, but don't be surprised if it takes longer. I don't know. Is that what you're seeing with some of your clients? Yeah.
Yes. Yeah. We've definitely seen that. And once we get I think the hardest part too, honestly, is a lot of the female athletes, there's also the kind of misconception potentially that like lighter is faster. And so just there's that mental component of like consuming more calories and the fear of slowing down and maybe gaining body fat. And, that I think is one of the hardest parts that we're not trained in. So it's finding those resources,
I would just combat that. Just a takeaway would be just a very simple thing. Estradiol that you make from eating enough and moving towards ovulatory cycles is anabolic. Like it builds muscle, it fuels the mitochondria. It kind of supports the mitochondria. Your listeners probably know what mitochondria are.
Yes.
So estradiol is performance enhancing. So you can eat for that, for the performance enhancing qualities, benefits of your hormones rather than fearing them or, I would say the performance enhancing aspect of ovulation is going to overcome like any, fear about, a little bit of extra body fat. I mean, a bit of extra body fat probably will come along with this, but often, I don't know, in the athlete population, but certainly in the non-athlete population, people fear that too. And I just find with my patients, it's not as much as they think it's going to be. Like, yes, you get a bit rounder, like often the estrogen gives you kind of rounder bum and kind of that, but that's what that's the female body is supposed to look like that. Like that's a sign of health. So usually, people are often surprised that they don't gain as much weight as they think they're going to. So it's this approach of kind of all in, commit to it for the long game is the only way.
And would you suggest them, for example, like, have you heard like the 30 to 45 kilocalories per kilogram lean mass recommendation?
I'm not versed in all the calculations that sports nutritionists do. I mean, I know this is a thing depending on your sport and you have to calculate and the lean body mass. No. So I would say, it's a general observation. It's usually a lot more calories than women think. And I would argue that at least for some women, some of that has to be carbohydrate or starch. So that's probably going to depend on the individual and the sport. I don't know how many of your listeners are low carb or trying to do that kind of thing, but
hopefully very few. Hopefully very few.
Okay.
Yeah. We try and discourage that. We're definitely with our athletes.
Yeah. I mean, you hear women saying, oh, I'm keto and I'm fine. I kept my period. It's like, I accept that can sometimes happen, but I think a lot of women, and maybe depending on ancestry, like I talked about earlier, losing that carbohydrate signal means their hypothalamus and their brain decides this is not a good time to make a baby. Something is very wrong with the world if I can't get the starch that I need to fuel. So
that is very interesting. I think I've only had one client where that situation happened, where they really preferred to go lower carbohydrate, and they said they were feeling good and like their cycle was still there,
but kept their cycle.
But what you mentioned too is like that and we don't know if she was potentially could have been that anovulatory cycles too. Right. So that was something that we didn't look into with the basal temp tracking or the urine test strips, but that's a very interesting area to why some women can get away with it in a sense,
I think it's genetic ancestry. I think it's age to some extent. I find that older women in their late 30s, 40s are going to be able to get away with that for probably a combination of reasons. The young or early 20s, that's the age group that I just seem to, their cycles are less robust at that age, but their brain's still figuring it out. So before we finish, though, I want to just do a touch on if you lose your period. Obviously, the assumption in this population is it's from underfueling, but it's probably good to also get a workup and just try to assess from a blood test if that's what's going on or if it's something else. Understanding that when stopping an ovulation suppressing drug, i.e. hormonal birth control, they know this from the research, there can be just a bit of a lag time in terms of the ovulation picking up again. But usually the ball, give it 3 months. If there's nothing happening after 3 or 4 months, get some blood tests to make sure there's nothing else going on apart from under eating.
Yeah.
And, the doctor will look at there's more obscure things like high prolactin or a thyroid problem, or I will mention, early menopause, which can happen, but it's unusual. It's only 1 in 100.
Wow.
For a 30-something, 30-year-old woman, it's really, I guess 1 in 100 is not nothing, but it's unlikely to be that.
Yeah.
And that's easily picked up, early menopause, easily picked up by high FSH. That's a particular blood test. Then the other thing that gets raised sometimes as a diagnosis is PCOS, or polycystic ovary syndrome. I really wanted to talk about this before we finish today, because there's a lot of confusion about PCOS.
Yes.
I have a blog post called, I have a few blog posts about this. One is called, is it hypothalamic amenorrhea or PCOS?
Okay.
And also a blog post called PCOS cannot be diagnosed by ultrasound. So here's the thing. Here's a basic piece of information that people need to know. Underfueling, REDS, relative energy deficiency in sport, hypothalamic amenorrhea, whatever you want to call it. That's in that state, you can have polycystic ovaries easily. Like polycystic ovaries is a non-specific finding. This is what I'm talking about now, this on an pelvic ultrasound and the observation of above a certain number of follicles or eggs visible in the ovary at that time. Keep in mind, that's a snapshot in time. The ovaries are constantly making follicles and absorbing them. And there's just a very dynamic change happening with the ovaries month to month. So you could be polycystic 1 month and they're not cysts. They're eggs. The name of the condition is completely wrong. A lot of experts are calling for polycystic ovaries to have a whole different name, because it's nothing to do with something wrong with the ovaries, which is not to say, just to be clear, there is such thing as ovarian cysts of different types. That's a separate condition. That's
interesting.
This what we're talking about has this silly name attached to it. But anyway, so in the state of REDS, which we're talking about today, you can very easily have polycystic ovaries. The polycystic ovaries means nothing. It just means you haven't ovulated that cycle, which you already know because you're not having periods. It's also possible to have high AMH, or anti-Mullerian hormone, in the under-eating state. So there's a lot of overlap diagnostically between hypothalamic amenorrhea and PCOS, both mainly in terms of the polycystic ovary finding and the AMH. They both, those two findings cannot differentiate the two conditions. Right. Yet PCOS is a very different condition than hypothalamic amenorrhea in that it's a high androgen state. It's kind of a high estrogen state, whereas hypothalamic amenorrhea is a low estrogen state. They both can present with anovulatory cycles or amenorrhea, which is also confusing. But here's a little way that I use to tell them apart. And that is LH. So there's a hormone called luteinizing hormone. PCOS is almost by definition, to a large extent, a high LH condition. I wrote a scientific paper about this, actually, about the high LH signaling and PCOS. That's a key part of it. And so often there's like a 2-to-1 ratio with PCOS. There's a 2-to-1 ratio between LH and FSH. On a baseline, not around the time of ovulation, because LH spikes up incredibly high around ovulation. So you need to be careful when you're measuring it. But usually I do like a day 2 or 3 FSH, LH. And with undereating, LH is low. It's usually, it might be 1-to-1 with FSH, but it's often really low. And so less than, 1-to-1. So then that is a pretty good clue. Other clues of undereating on blood tests would be a low fasting insulin as opposed to a high fasting insulin with PCOS potentially. And another just finding, if anyone's sort of, depending on, I don't know how much detail, if there's any practitioners listening. The other thing with undereating is high SHBG, or sex hormone binding globulin. It is often high with under eating. It's also high with hormonal birth control. So you need to, with an estrogen pill. So you need to sort of be, put that in context. But I hope that's helpful. I mean, I hope there are, because this is my message to any women out there who has been told, is clearly in a state of underfueling, and then been told she has PCOS and is confused and wondering if she might maybe need to eat less, because often the mainstream advice for PCOS is to eat less, which is a disaster for this group. So if that makes sense, if you're mistakenly told you have PCOS and you actually have under eating, and then you read that you should go low carb for PCOS, this is really bad. And you can see why I wanted to get this into this interview, because it's common, it's happening.
So treatment options, basically, if it's hypothalamic amenorrhea, or however that is gotten to that point, or PCOS, the treatment options are almost opposite of one another.
So, I mean, generally they are. Yes. So, and which is not to say, I mean, there's a little bit of gray area in that you might have someone who's under fueling currently, but does have sort of a genetic, maybe PCOS tendency, maybe has a few androgens. That's a little bit more complicated, but I guess even in that case, if there's any evidence of underfueling, you fix that first, and then you deal with, the androgens and the PCOS side of things. There's other ways to treat. I mean, there's on the PCOS side, there's all the whole conversation of, is there insulin resistance or not? Or if it's a non-insulin resistant PCOS, then you can look at certain things. I'll mention the supplement inositol, which is wonderful for PCOS and promoting ovulation, and is fortunately safe to take even when you're under fueling. It's not going to interfere with that side of things.
Do you know what dose range was shown to be most effective?
It's been clinically trialed. So inositol is one of the few supplements that is fully evidence-based. It was included in the international guidelines for PCOS.
Awesome.
It's in the 3 to 6 gram range. So it's quite a lot. So you need a powder to get that.
Awesome. I know we're hitting time here, but this has been such an amazing conversation. And I mean, there's so much more I could ask you questions about, and I know you could give us so much more information here, but I will be respectful of your time and just say thank you so much for your time today, for joining us. Potentially, we would love to have you on another time, maybe to dive into more PCOS conversation and other topics. But this has been super amazing. And we appreciate your time immensely, and we'd love to have you back one day. And then we'll also be tagging or including in the show notes all the blog posts you mentioned, and then maybe just a quick kind of blurb from you on where our audience can find you. Where can people find you to follow you, learn from you? Where should they go?
For sure. I'm going to give you that. I'm also going to say, if you have me back, we should talk about endometriosis, because that's another thing that affects everyone, whether they're athletes or not. So I'm easy to find. I have 2 books, Period Repair Manual, Hormone Repair Manual. Period Repair Manual is for the under 40s. And then I have a forum, which I've just launched in the last few weeks. So it's a place where both just individuals and also practitioners can come on and discuss some of the women's health topics. So I'm trying to sort of moderate that, and I'm hoping I'm going to get some very smart, savvy practitioner types chiming in there, so that could be great. So all of that's at larabriden.com, and all of my social media is at Lara Briden.
Perfect. Amazing. And her book, Period Repair Manual, I highly recommend it as well. I've read through that one. Just the way you even structured the information in there is so helpful. Amazing. So again, thank you so much for your time, Lara, and we will speak with you soon, I'm sure.
Thanks. Take care.
Awesome.